Hi, everybody. This
Uh,
is Dr. Arthur Zembowitz. I'm here with Dr. Jennifer Koh from Cleveland Clinic, and we will be talking about melanocytic tumors in the skin. Um, Jennifer, how are you?
Good. How are you? Thanks for having me today.
Yeah, so Jennifer is a rising star in dermatopathology. She is the person in charge at Cleveland Clinic in terms of melanocytic tumors. And she also made already significant contributions to the field. And we had a chat last year during melanoma meeting. We were seated together at a dinner table. I thought, and I came to a conclusion that I have to invite Jennifer, and she kindly agreed to come and share her experience with us. So I'm really happy, Jennifer, that you're here, and I'm really looking forward to this seminar. Okay, so I think that is it in terms of introduction. So now let's go back to cases. So Jennifer, this was the first case, and
Yeah, so this was a case that we received from a 28-year-old woman on the cheek. And at low magnification, you can see that it's got some squamous hyperplasia, so hyperkeratosis, acanthosis of the epidermis. And in the dermis, you see tumor nests. And the cells have abundant amphiphilic, somewhat vacuolated cytoplasm. I would say mildly enlarged nuclei with open to vesicular chromatin and prominent nucleoli.
mhm.
So
Any junctional component, maybe
there
some.
was a focal area here in
Mhm,
the circle where it looked like there could be some junctional
mhm,
involvement and some vertically oriented nests.
mhm. Yeah.
And the cells are quite monomorphic.
Mhm,
So we did immunohistochemical staining, and in the top left, you can see that's SOX10 staining.
mhm,
And in the top right, this is S100 staining. And I think this is important because if you look at the Langerhans cells in the epidermis, the S100 staining is quite pale and patchy and variable. And in the bottom left and right, you have melanate and HMB45, and they're completely negative. So what do you think this could be?
So these are the
Did they
choices.
answer it like when they saw it, or are they answering it now?
No, this is actually from the preview.
Okay,
Yeah,
okay,
this
great.
is from the preview. So people had time to study. And actually, from the choices that were provided, I think people did very well. This is a
Yeah,
tough,
they did
huh?
very well,
So you guys are
especially
awesome.
considering no stains, right?
Yes, this is just based on H&E, and obviously, you choose the highest probability. But I think, yeah, that's a really outstanding performance for our participants. 50% of people made a diagnosis of this entity.
Yeah, so CRTC1 TRIM11 rearranged tumor. I wanted to show you a few other cases. Um, so in this case that you have here is similar to the one we just saw because, you have hyperkeratosis and hyperplasia of the epidermis. The SOX is diffuse, the S100 is pale, and melanate is negative. And when you see this squamous hyperplasia, I think that Spitz tumor, atypical Spitz tumor, definitely comes into the differential diagnosis. But it's important to keep the CRTC1 TRIM11 in your differential. And then when I see this staining pattern, it's almost always been that it's one of these tumors.
Mhm.
And here's a closer look at that case. And, there's some variation in the cytomorphology, I think, but in every case, the cells are monomorphic. Here you can see a little bit of vague palisading of the nuclei and occasional multinucleated melanocytes. But again, you've got sort of the spitzoid cytomorphology with the open chromatin and prominent nucleoli. And the next slide shows another case that we had. You can't see the epidermis here. It's a completely dermal tumor. Now this one is a little bit more aggressive looking because the nucleoli are more enlarged. And the nests are a little bit more rounded, and there's this thin fibrous septations in between the nests.
Yeah, I would think about a clear cell sarcoma having, seeing that particular case.
Yeah, and also another tumor that's going to come up later in this presentation of one of our other cases. This one is all dermal. You actually have attenuation of the epidermis, and you can see that the cells are more fusiform and spindled, and again, almost palisading like Verricae body formation with this fibrillary background. And there's lots of mitoses in this case. Another one with the squamous hyperplasia, nested at low power. And then here you see like kind of whirling of these nests superficially. And there were, scattered mitoses in this case as well. So I think
How did you get that many cases?
they're all mostly consults, I have to
Yeah.
say.
Yeah.
Yeah.
That's
And we have so our Archer sarcoma fusion panel, we added CRTC1 and TRIM11. So sometimes we even get a case from like another academic center because they don't have the molecular test.
Yeah, that's remarkable that you have a good series of those rare cases. Yeah. So here you ask a question: what immunohistochemical stains would you want to do in which order?
Yeah, I mean, this isn't really like a right or wrong answer. Um, but it's more just for like discussion purposes. So, when you see this tumor and it's predominantly dermal and it's very monomorphic like this, you definitely want to consider the what we consider like the MITF activated cutaneous tumors in that category of clear cell sarcoma, CRTC1, TRIM11 tumor, and others that we'll discuss later. So I think the most important thing is to do SOX10, S100, melanA, and HMB45, because if you have just pure SOX10 expression, then, that really is, pretty specific. And then you can confirm with molecular, or some people have a TRIM11 IHC. I know Arno has a TRIM11 IHC. So I see someone asked in the chat, should we address the chat question?
Yeah,
Okay.
or now, or choose when in your
Okay, well, I just want to mention another thing you could do is BRAF and NRAS. So, I mean, it would be rare because, dermal melanoma could be in your differential diagnosis. And if you had a BRAF or NRAS mutation, that would be your primary consideration. So just to summarize here, CRTC1, TRIM11 tumors, they're part of a group of MITF activated gene fusion defined tumors. They have melanocytic differentiation, but there's not been proven clear melanocytic histogenesis. Some clues are a nodular dermal tumor with no pigment. I've never seen them with pigment. Monomorphic and spitzoid cytomorphology, and then diffuse SOX10 staining with variable patchy or absent staining for the other markers. So I just did a literature review. There's been 50 cases reported thus far, and 6 of those have progressed. So one was with the local recurrence, one was with local recurrence only, one was with a spread to regional lymph nodes only, and then 4 spread as far as the lungs. And one of those 4 had a known TERT promoter mutation, and one of those has been reported to have died of disease, although I would assume that the other ones would probably eventually succumb to disease. And so because of that, I think a lot of people are managing this similarly to melanoma, and they're in the sense that, you know, you maybe want a 1 centimeter margin and maybe consideration for sentinel lymph node biopsy, or at least serial ultrasound monitoring of the draining lymph node basin. Um, I personally have not had a systemic metastasis in any of my cases. I haven't even had a lymph node metastasis in any of my cases, so maybe I'm just lucky.
Mhm.
But, you know, I know one of the fatal cases was published by Pedram Jarami, and it was a 5-year-old, and that was the case where the patient ended up dying. The only molecular that they mentioned was that they thought maybe there was low gene expression for P16, uh, but you know, otherwise there was nothing in particular to set that tumor apart. And so that's why I think, you know, people are advising maybe to treat as melanoma. The other thing I would mention is based on the molecular findings, I think it might be more likely to respond to clear cell sarcoma type treatment rather than melanoma type treatment, meaning immunotherapy, because, you know, probably we're looking at a low tumor mutational burden and not a lot
Mhm.
of driver mutation, or not a lot of passenger mutations that would be antigenic.
Yeah. So it is a kind of melanosarcoma. I always think about these
Yeah,
tumors as melanosarcoma. Yeah.
maybe like a low grade
Yeah.
melanosarcoma.
Okay, so that's it about that entity. I'll see if there are any questions in chat. I mean, you answered a question about distant metastasis. So I think we can move on